Good Friday morning, everyone. Welcome. I'm Dr. David Wild, Vice President of Performance Improvement, here in the Dolph Simons Family Broadcast Studio with Dana Hawkinson, filling in for Dr. Stites this morning. Today we have Amanda Gartner as well, our Director of Infection Prevention Control Quality Magnet. Lots of things. She'll be joining us from Studio B here shortly. Dana, to get started, we did a little better yesterday.
We did.
How did we do overnight?
Well, we've done okay. Again, we want the number of inpatients and active infections to be like the golf score. The lower, the better for everybody, for the community, for our health system. Today we have 78 acute infections, so a lot better than that high 80s that we were at. We were almost pushing 90. 34 of those in the ICU, but unfortunately 21 are on the ventilator, which is a higher proportion than we've had really these past few weeks. We've only had very small numbers or small proportions on the ventilator, but 21 of 34 patients in the ICU on the ventilator. Overall, we have 47 other people that are in that recovery phase. So it's about 125 patients total, and 2 of those 47 remain on the ventilator as well. Overnight, we did have 2 deaths and 119 deaths total attributed to COVID here in the inpatient, in the hospital, but also in the outpatient setting as well that we have tracked. Unfortunately, Hayes, though, is still having very high infections, 35 total, with 33 of those that are active and 2 in that recovery phase. So that's a large proportion of their hospital beds. And they did have a death in the last 24 hours as well. So.
And, as you talk about that 125 total number, really people taking up beds that wouldn't be here if it weren't for COVID, that number has been steady now for the past week or so, 125 to 135, pretty much every day. It's very little variation.
Yeah, and I remember when we had 60 to 70 total taking up beds, and we were concerned if that number went up because it is taking a bed. And there are other problems that are out there: heart attack, stroke, typical infections, other types of pneumonias, things like that.
We'll get to questions that you've been submitting all week and also questions live today in just a few minutes. But before we jump into those, I did want to share some numbers, some slides to sort of address the questions about what's happening that we've been getting frequently. I'm not going to spend a lot of time on the first few. These are very, very similar to what you have seen before. Again, setting the stage. We know that as cases, the red line increases here nationally, so do the number of people needing hospital care, the blue line. We continue to climb. We have not yet turned a corner in slowing new cases per day, and we anticipate that the number of patients in the hospital will continue to climb as that curve, the new cases curve continues to increase. The next slide is the regional look. And the Midwest, you can see, remains high, over 915 cases per million per day on average, new cases in the Midwest region. The other regions continue to show increases as well, and that's concerning as areas that have seen very little spread over the past several months for whatever reason related to most likely to measures that have been put in place to mitigate community spread in places like the Northeast, for example, but everywhere now seeing a pretty rapid increase, that fall surge that we've been worried about, and definitely not turning the corner in any region, at least at this point. The next slide brings us back into the state level, looking at both new cases and hospitalizations. You can see the sort of shaded red bars in the background on the new cases for Kansas, showing that our number of new cases per day, the actual number each day, is very, very close now to that of North Dakota, which we've talked about as being sort of the epicenter, the worst of the worst recently. And you can see the slope of that red line for average number of new cases per day being nearly vertical for several days in a row now. Very concerning to us as we think about what's likely to happen over the next few weeks as it pertains to hospitalizations, which you can see on the right side, the hospitalizations, the per capita, per million residents for Kansas and Missouri, both continuing to climb and climb rapidly. The next 2 slides just address the metro area. This here showing the solid line being the average number of new cases per day in the Kansas City metro. This is the STAR data. Unfortunately, that little drop that it looks like you can see at the very far right, if we saw a version of this with yesterday's data, would show that this turned right back up, the highest number of new cases we've seen per day in the metro, driving up the average yet again. And as we move to the last slide, pay particular attention to the shape of this curve. This is the number of patients in the hospital in Kansas City for a core group of hospitals. So it's not the actual complete number. It's a group of maybe 8 or so hospitals, 10 hospitals that have been sharing this information every week since early March. We're doing a lot better job of having a good sense, sharing a good sense about what's happening in all of our hospitals now, but we've only had data for about 8 since March. In any event, the shape of this curve looks exactly like the shape of the curve of new cases. And so as that line continues to increase for new cases in the Kansas City metro area, we expect, really without any doubt, that the line or the curve of the line for those in the hospital will increase as well. And finally, so that's maybe to set the stage, right? That says we continue to be concerned. We are not seeing the number of new cases in our community change. We know that the hospital impact is going to continue to grow. And that sets the stage for the rest of our conversation for today. Before we get into that, lots of questions recently about the demographics of October and November deaths. And so this may actually feed some more questions, but here are some statistics for you, the numbers. So total for October and November, for those patients that were admitted to our hospital here in Kansas City, we've had 22 deaths. That's an in-hospital mortality rate of 4.8%, which is actually lower than the average for the entire pandemic, which is about 6%, and lower than the last 3 months, which is about 5%. So more people being hospitalized, smaller percentage of them dying. It's still not a small percentage. 5% of any one disease being hospitalized, not surviving is definitely not a low number, but nonetheless, it is coming down as time goes on. So, of course, as we have more patients in the hospital, I think we talked earlier this week or last week, more than a third of our admissions have happened in the last 6 weeks. A third of the total admissions to the hospital since March have happened in the last 6 weeks. As more people get hospitalized, even a decreasing percentage, right? 5% of a bigger number is still a larger number of actual deaths, and we know we've shared that story. The average age of those not surviving here is 64. 100% of those patients that have died in the hospital have needed ICU care or have been in the ICU at some point in their stay. This is one of the shocking numbers for me. 16% of those patients that did not survive had no coexisting disease when they hit the hospital. So we continue to talk about the fact that this is not just a disease of the elderly, not just a disease of those that have chronic disease. We're seeing the same patterns show up in the morbidity numbers as well. And finally, just looking at the percentages of those deaths, those 22 deaths for patients that have not been from the Kansas City metro area, 52% have been, which is actually lower than the percentage of the patients in the hospital that are from the metro. So that's interesting. We'll continue to dig into that. That's likely because a larger percentage of those coming from outside of the metro are being transferred here because they need very specific ICU level care. That's my explanation at this point, but we'll continue to dig into that to understand if there's anything else we need to share to make sure you're all aware of. So that's what I brought as far as numbers to sort of keep everyone up to date about where we're at now. Jill, before we jump into community questions, are there any reporter questions this morning?
Hi, good morning. Cody Holyoke with Channel 9. How are you today?
Doing well. Hi, Cody.
Hi. We've seen a number of articles recently, great news about vaccines from all these drug makers, specifically, though, about kids and how, because of the vaccine process and the trial process, they're not being tested necessarily on children. Would this mean, just for the layperson, that children would not be able to get this coronavirus vaccine right away, or that more study would be needed? How does that work?
Yeah, I think in general, that's exactly what it means. We know that for the EUA, for the monoclonal antibody, specifically the one for Eli Lilly, the bamlanivimab, we know that it is the EUA, the emergency use authorization, is for those 12 and above. So just applying that, we know that if there's not enough data the EUA for the Pfizer vaccine will have a specific age, probably 18. I don't know, but there probably will be a specific age. In the meantime, Dr. Pahoud and Dr. Castro were on yesterday talking about vaccines. There will be continued studies, so we have to wait and see what is in the EUA. But we know that for those EUAs, for treatment, for vaccination, there will be specific age cutoffs.
Yeah. So the phase 3 trial, right, the study group that this early efficacy data has been based on excluded anyone under 18, excluded those over 65 in most cases, and those with chronic diseases, and also pregnant women. And the other thing to note about that phase 3 trial group for both of these vaccine candidates is that the number of minority participants in the trial was less than the percentage of minority participants in the general community. So it is likely that we will see some differences in the efficacy numbers as the population being vaccinated expands to look more like the general population in our country. But I think still lots of promising news there. And a point of clarity maybe on the will children be able to get the vaccine first. It is fairly clear in both the CDC and the state distribution plans that healthcare workers will, on the front line, will be among the first vaccinated, and then it will move to those at high risk, which in most cases will not be children. So I think it's safe to assume that we won't be vaccinating children in the first wave, and probably not until later in the next calendar year.
More reporter questions?
Hi, this is Celia at the Kansas News Service. I apologize if you already answered this. I could go back and listen later. But do you have any thoughts on the governor's new mask order and what you would like to see counties do, since county commissions have a little bit of time to make a decision, and whether it would be helpful if they followed that order, in your opinion?
Well, I'll start on maybe the first answer, and then I think Dana and Amanda would both weigh in. I think in general, anything we can do that increases adherence to masking across our state will be beneficial for all of us. I think the mask order, as outlined here, this time around, does really appear to give everyone the opportunity to decide over the next week or so, maybe a slightly shorter time frame now, what is best for their community. But I do think that we would all be supportive of more counties adopting something, and definitely something very similar to the governor's recommendations based on the impact that those interventions will have on the spread of disease in our community. Dana?
Yeah, absolutely. Nobody likes to wear a mask. We don't like wearing masks. We don't like to go out and wear masks and see friends and family with masks on. But masks are safe. They're not going to impair gas exchange. They're not going to make you lightheaded or weak or anything like that. Most of the people, most of the general population, unless you have very specific medical problems, most of the general population can wear a mask. We've also seen that, especially in Colorado, which adopted a lot of mask measures very early on for their survival because they needed tourism. We know that has gone very well. We know that recent publications, there was a recent publication in the Morbidity and Mortality Weekly Report out of the CDC that showed mitigation strategies, including masking, do help and reduce infections, reduce hospitalizations, and reduce deaths. So it is very incumbent upon every community to understand the dynamics in their community. But as we've seen, infection is just widespread, especially in Kansas right now and in the Midwestern states. So I think it would behoove everybody, for their friends, for their loved ones, for their businesses to stay open, to continue to enact those mask mandates.
Amanda, anything to add?
Asking we can encourage, the better. We know it works and we know it prevents disease.
Yeah, I would agree. All right, Jill.
More reporter questions?
I'll just follow up real quick with, what is the biggest story surrounding this virus that people aren't talking about right now, in your opinion?
I don't know.
Yeah,
I haven't talked about it. Let me think about that.
Yeah, you guys talk about so much, so I just didn't know if there was something that's weighing heavily on you or anything.
I think I have an idea.
Okay.
Something that we don't talk about very much is ourselves. and our workers. And we have had a lot of questions this week and chatter around how are our teams holding up and what are some of the hardest parts about their jobs and the most rewarding part about their jobs right now. And I think all three of you would be great to answer that.
I think that probably is one of the more untold stories. Our teams really find it important to be able to offer the best possible care to anyone who needs it and as many patients as we can. And everyone's working real hard right now. And that's an understatement. And everyone's tired. And I think everyone still has the desire to provide the best care possible for anyone who needs it here. And I think we've talked a lot about how that's getting harder just from a perspective that more patients are needing that care. And so that weighs on us too. Dana, you've been out and about on the floors probably more than any of us from a clinician's perspective.
Yeah, I mean, certainly workplace stress, talking with the nurses. We've talked about the shortages. So we have talked about that, the workforce shortages for nursing, for respiratory therapy, for these specialists to take care of it. But I think one of the more untalked about or discussed stories is really the other public health officers, and not just in the urban communities, because we know how hard the urban communities are hit, and we know the impact of the infections and the hospitalizations. But in the rural communities, there are still a lot of the general public who don't want to wear masks or adhere to public health guidance, and taking the brunt of that is those rural public health officers and those nurses that are doing those jobs every day to try and encourage those things. We understand what will help, but still there are groups and populations who do not want to do it, who dislike the public health officers, the nurses working for the health departments. We have to remember that we are all doing this healthcare because we care about people, and we want people to be well individually, but also as a population. So I think that's one of the stories that really isn't being talked about too much. It is important to let our rural health partners know that they are supported and continue to get out the good message to really try and stop the spread of this disease.
Amanda?
I think the only thing that I would add is that despite everyone working so incredibly hard and being very, very overwhelmed and just worn out, there is still this element of positivity that they're in this together, and we've got this under control, and we're going to make it through this. I know from a bedside clinical staff perspective, I've got two different teams who are supporting different roles that previously we didn't even have in the healthcare system. So, they've transitioned the work that they're doing to support our employee hotline and our swab clinic. And every day they're asking, what more can they do?
Yeah. Excellent point. As you walk around, you can see people are tired, but there is absolutely still this feeling of together we can tackle this. And we will, I think, all continue to do our absolute best. And that feeling definitely is palpable as you're out and about. So, all right. Any other reporter questions?
I have another, because we know that, the way incubation periods work and the way that spread can be exponential or is right now, if people started following all of the kind of infection control measures that you recommend tomorrow, this current spread would still continue for a while, right? How long would it take to bend the curve?
Yeah. So you're right. An incubation period means that the infections that we are seeing test positive now are from interactions most likely 5 to 10 days ago, maybe a little longer, but most likely 5 to 10 days ago. So we have seen repeatedly that it takes about 3 weeks after any change in behavior to begin to see a reduction in new cases. So a little while from now, and of course, what happens in the middle of that 3-week time frame? Thanksgiving. And what happens 3 or 4 weeks after that? Christmas. And it's the reason we continue to harp so much on the importance of doing everything possible to mitigate spread at those times as well, because it sure looks like it could be a setup for things to be much worse than they are right now if we don't change what we do and change pretty rapidly.
Yep. Yeah, I would agree. There's always the delay. There's that delay from the first infections to the hospitalizations. And we know there's the delay in deaths from those hospitalizations. But if you're thinking about incubation periods as well, we have seen the delay. Most notably when it was Memorial Day. We didn't see a large surge in further cases until really 4 or 5 weeks after that. So the minimum amount we're probably going to see is that 3 or 4 week period. It probably will take 2 to 3 infection cycles to really understand what is the full impact if everybody is being responsible and doing their due diligence and taking these measures into account in the proper means.
Yeah, I keep using this phrase, but this is very quick to get worse and very slow to get better, right? People are in the hospital for 4, 5, 7 days if they're not in the ICU. If they're in the ICU, it may be 15 or 20 or 30. And so it will take some time before we see the benefit, of those behaviors changing in new cases, and even longer on the hospital side. And so we have a bit of time that we'll have to work hard to work our way through this. All right. Jill, maybe on to some community questions?
Sure, if the reporters are done. All right, Sarah wants to know, is age considered a comorbidity? What are the top comorbidities that place a person at risk?
Yeah, age absolutely is a comorbidity. We saw in our recent demographics, just from deaths in October and November, they were in their mid-60s. So certainly we know that age above 60, but especially above 65, it puts you at higher risk of hospitalization and death. We know other comorbidities such as obesity, diabetes, high blood pressure, coronary artery disease, lung disease, and other immunosuppressing conditions, whether it's chemotherapy or bone marrow transplant or something of that nature. But I would say for the general public, as we know that age is out there in a large predominance, 65 and above, but we know other very common comorbidities such as obesity and diabetes, probably because they are so predominant in the community, are probably the largest risk factors.
Mary Lee has a question. She's up in Skidmore, and her question echoes several scenarios. We're getting this question repeatedly, just different scenarios. She says her young adult son had symptoms and tested positive in early November. Now he's back at work. She wants to know, is he safe to come over for Thanksgiving?
Yeah, this is a difficult question.
Yeah, I think we know a couple of things with certainty, and then maybe Amanda and Dana will save me here, but we know that the period in which viral transmission, viral loads are high enough to actually create active infection risk, transmission risk, is about 10 days. Yeah. And that is the reason for the 10-day isolation period. And it's the reason it hasn't changed. The science is pretty sound there. So that part we know to be true. If you're worried about, does he have virus actively transmitting to others after 10 days, the answer is probably no. That's very different, though, in my mind, than is it safe? And
correct. That's the difference. And I don't know what Amanda would think about that as well, because they are two different answers. You're exactly right.
I think the concept of what is safe is we really have to evaluate the current bubble practices. And is your son currently living with you? Is he introducing a whole new bubble to your home? And again, as Dr. Stites has mentioned over and over and over, we really have to evaluate the risk to benefit. Is it worth it to you to spend some time with your family, or is there enough risk with your health or your well-being that maybe it makes the most sense for him not to come home for Thanksgiving? And that really is a personal choice.
I'd reiterate, I know I said this earlier in the week, but there are also other reasons besides just the COVID conversation. So we know, that these same mitigation measures for COVID-19 are helping us prevent a bad flu season. And so, even the chance to reduce influenza transmission by masking and keeping your bubble small, even if COVID-19 isn't specifically the issue at hand because you've recently tested positive. There are still many, many other reasons to help us keep the community safe as a whole. So I know hard questions, lots of scenarios. Unfortunately, the answer is usually the same in all of them. It's best and safest if you spend Thanksgiving only with those that live in your household. And any other addition from there, short of maybe circumstances where everyone has quarantined for 14 days before you get together, offer some degree of risk. And so I think the safest answer remains the best advice we can give you is spend Thanksgiving with those that live in your household.
I have a question from Vicki and Lisa, and then we're going to get to our list of questions. All right, that's a cue for the master control. Vicki and Lisa want to know about, apparently the World Health Organization came out and started talking about Remdesivir. So they're asking about, plasma convalescence was all that, Remdesivir was all that. I think they're kind of wondering, what's happened with that and monoclonal antibodies? Are they going to be all that?
Yeah, it's a good question. I'll tackle the first one. Plasma certainly looked like it was possibly beneficial. There was some signal from the large Mayo studies that people did improve or not progress to severe disease. But those were people who got plasma within 3 days, and they also got very high titer plasma, high titer of antibodies. There were further studies now that have shown that it probably isn't of benefit. So we have really kind of gone away from the EUA of the plasma here at the hospital. It can be considered, but we are also involved in another trial with Vanderbilt University, led by Wissam Elatruni here, with high titer plasma. So we are still looking at that. That is still in the trial mode so that we can get definitive data. For Remdesivir, that is a very good question. The World Health Organization did come out yesterday or the day before that saying that it probably doesn't help. However, it is still in the United States, the NIH COVID treatment guidelines. There is just a little bit different interpretation of the studies and what studies. For the World Health Organization, it was a solidarity trial that really didn't show benefit. There have been other trials here in the United States. So currently it is still on the NIH guidelines for treatment for Remdesivir. But again, you need to treat in the viral phase. So really getting that drug 10 days, or probably even better, 7 days after within that 7 days from your symptom onset, you're probably going to have the most effect. There still are studies ongoing, so we will change as the data directs us to. For the monoclonal antibody, that is still being studied. We know that one of the major causes of the EUA getting approved is that phase 2 trial. So very early preliminary data. That does look like it will be beneficial, but again, there are caveats. We need to make sure that it's given within 7 days of symptom onset for the maximal benefit. There is still the trial ongoing looking at it as well, so we will adjust and change our strategies as new data becomes available.
I think it's important to recognize for all of these options, right? You've listed a number of treatment options in the question. For all of these, what we're learning is that timing matters. Sometimes sequence matters. Early treatment is better. Generalized, this is a silver bullet, a panacea. Treatment options really haven't appeared, and that's not surprising. And maybe just another very general statement, but we are learning about this disease so much faster than we have learned about nearly any other disease in the history of medicine. And it's happening on a very public stage, right, because of the impact. And so we are treating or making treatment plans and guidelines based on phase 2 or limited phase 3 data, which normally wouldn't happen for many diseases. And that's also part of the reason why things are changing so often. So you're living this and seeing it play out in real time in ways we don't normally. And that doesn't mean that any of the information is wrong. It means we're learning, and that's a good thing.
All right, let's get to the first of 10 community questions from the week. Why don't you think spread is happening at schools when staffing is way down due to COVID-19?
So I'll hand this to Amanda here pretty quickly because she's been out and about providing some guidance to our schools. But I think what I would say is, from my perspective, I think I would qualify that statement a little bit. I don't think there's widespread transmission in most classrooms.
Yeah.
That's different from saying that there's not transmission in schools with all of the other activities that happen. So, yeah. Amanda?
Yeah, I think that's an extremely important component of this answer, because I think the classroom itself is a very controlled environment where you've established good spacing behaviors. Masks are most likely required in each of these settings. We've probably honed down on activities that require closer contact, so we've probably eliminated those things. So I think, as you mentioned, in the classroom itself, the risk of transmission has been mitigated to a pretty significant degree. It's the activities afterwards that may be contributing to more spread.
Yeah, the other thing I might add to all of that, right, specifically around the staffing question, is much like the healthcare environment, we know that the majority of transmission for school staff is not in the classroom or even on the school campus, but remains in the community. And so that's the big impact on staffing. But nonetheless, it definitely has created a situation where there's obviously concern among our superintendents and school boards about the ability to keep enough staff to keep the classroom safe for all grades. So hard questions there. And I know from personal interaction with a number of the superintendents, really a lot of the superintendents across the metro, they are very, very focused on what's best for the education and the safety of our children. And they are working very hard to make hard decisions. So I think kudos go out to a group that really I wouldn't want to be in their shoes either.
Yeah, and I think the other thing to talk about is, just as we've seen here, the adults in the school, are they congregating? Are they eating lunch because they think they're safe because they're with each other every day? They're not using masking, they aren't distancing. They're in meetings, things of that nature. So it's very important for those administrators at the highest levels, but also in the schools themselves, to continue to re-educate and encourage their staff to be vigilant and do the right things when they are together or meeting or having lunch or anything like that.
Should I travel on a plane now? Airlines advertise that they're safe.
Well, you've been there.
I did it a long time ago in June. I don't know that traveling now is safe. Again, remember, the CDC just yesterday said really discourages any travel. Certainly car travel is safer than airplane travel, but the airplane travel, it's really being discouraged by the CDC right now because of such widespread disease in the nation. The airplane, you can wear goggles or a face shield and a mask. You can use hand hygiene. You are going to be in that airplane. From what we've seen, based on other articles and publications, that it could be pretty safe, but you are also in the airport with other people. You are interacting with a lot of people. So I think there are a lot of steps there in which you have that higher risk of contracting the disease.
Is it safe to put two COVID-19 positive patients or people in the same room in the hospital or at home?
Mm-hmm. So I know, Amanda, we've all had a number of conversations about this. Do you want to start us off?
Yeah, so we have not had to put two COVID-19 positive patients in the same room, fortunately, but I think we've decided that if we absolutely needed to, that we didn't feel that it would pose a significant risk to each individual patient. We've also identified that if you've got two family members who have COVID-19, most likely they are around each other, they're within their bubble, so having them what we call cohort together is likely not going to cause any significant problems for either one of them as well.
Yeah, I would agree. And we have debated this a lot at the health system for the safety of our patients. I think overall that, especially as Amanda said, if you're in the same household, it should be fine. Now, if these are two separate patients from, just two areas who are admitted and we need to put them in a room because we have no other rooms, I do probably feel it's going to be safe. The amount that one person, now we do try to mask all of our patients as well, but the amount of respiratory droplets that one person will breathe out and the other person could potentially breathe in. Again, we do have engineering in the hospital with air turnover. We will have separation as well. The amount that one person would breathe in is probably minuscule to the actual amount of virus titer that they're replicating in their body at the time anyway. So you are building up your immune response. So Theoretically, I don't necessarily have a problem with it, but we know other hospitals and other academic health systems are doing that as well.
Correct.
Okay, this next question 4. The phone's kind of blowing up with this again today, too. People are having a hard time understanding. The health system reports 900 plus licensed beds and only 120 some COVID-19 patients. That doesn't sound overwhelming. Why is the healthcare community feeling so stressed?
Yeah, so get ready for a lot of numbers here. You may need to get your calculator out. Yeah. So, Amanda will undoubtedly help me out here, but I'll start by saying licensed beds in a hospital doesn't always equal the number of beds that we can use for adult patients right now. So, for example, our licensed bed number includes semi-private rooms, 2 beds in 1 room on a number of our units. We're not using them that way right now, and so, as we mentioned, primarily in an attempt to say we want to be as safe as we can for as long as we can. If we have to use those rooms, we will, but that takes 45 or so beds offline. Also included in that licensed bed number are our labor and delivery rooms, which cannot be used for other adult care and need to be used for babies that continue to be born. Our nursery, our NICU, our pediatric rooms, and over 100 behavioral health beds on our Strawberry Hill campus and our Marillac campus, all included in our licensed bed number. And so those beds are not designed to be used to take care of medical needs or surgical needs, and they really aren't able to be used. Not only are they not designed, but it would be very hard. They don't have oxygen and suction and monitors in the same way. And so there are a lot of beds that come off the line from the perspective of what's available for COVID patients just from that. So to put that in perspective, we have 501 adult beds that can be used, non-ICU beds that can be used for medical surgical care here in Kansas City, and 133 physical ICU beds that can be used. So that's 634 physical beds. And right now, 125, we said this morning, of those beds are being used by COVID patients. That's 19.7%. Basically, 1 in 5 of our beds are filled with COVID patients. And actually, we've then added a significant number of beds. There are 700 and some odd, 703, I think, or 713 patients in our hospital this morning at 7 o'clock total. We have more patients than we have beds today. And that's because all of those other reasons that bring people to the hospital are still happening. Strokes, heart attacks, cancer, COPD, right? All of these things that we talk about that people need hospital care for just haven't gone away. They don't go away because of COVID-19. And so we put those things together, 125 patients in our hospital that wouldn't be here on a normal day if there weren't COVID, plus all of the patients that are already here, more patients than we actually have physical beds available for adult medical surgical care. And we're stressed. I mean, if that doesn't paint a picture of why it's hard and close to overwhelming and why we're worried that a flood, right, of 10 more patients would be really challenging, let me know and I'll try to run through it again. And maybe I'll reinforce one more time. There is not another disease process, not cancer, not heart disease, not anything, not one other disease process that takes up 20% of the beds in this hospital. Not one. And we have never had a flu season, for example. We continue to get that question. Well, right, you know, how is this different from a bad flu season? The H1N1 flu season, right? A bad flu season requiring a lot of hospitalization never had 125 patients needing to be hospitalized at the same time. I think those are the things that I would say to start off answering that question. And Amanda or Dana, I know, Amanda, you were giggling in the background about the 900 licensed beds. Anything I missed or anything you want to correct me on?
I'm laughing because the light keeps shutting off back here, so I'm just sort of sitting in the dark. But I think you made the point that I was going to mention is that it's the 120 additional beds that we don't normally have to account for. And that's really displacing the other patients who have other illnesses that really need hospital treatment. And that's where the stress is coming from. It's delaying surgeries that need to be done or just having medical conditions that we are having a hard time placing these patients. And that's not just within our community, but David, as you know, the transfers in that need the acute care that we can provide here, we're having a difficult time accepting all of those patients as well.
All right, question 5. I thought my mom was having a stroke by the sounds of her speech over the phone, but tests showed it was foggy brain from COVID-19. We never would have guessed that. Can you list the primary symptoms you're seeing with patients now?
Yeah, without knowing the details of that, I don't know. We would probably say encephalopathy here as a medical diagnosis. I'm sure that she was worked up with MRI or CT scan of their head, possibly even lumbar puncture. We understand now that some people, especially those over 65, may present only with that symptom. There was a new report out just in the last 24 hours about this type of symptom, about encephalopathy or confusion. I know that myself, I saw a patient who was over 65, obese, diabetic, really presented only with that, with encephalopathy. Got better after a couple weeks, but really never needed oxygen or anything like that. As far as symptoms go, I think for the acute phase, that viral phase, I think the most common symptoms we're seeing is aches, fevers. Because they're having those, they're coming to the hospital because they feel so bad. Maybe some cough and shortness of breath. But then if you're coming to the hospital now later, also with those early symptoms, loss of taste, loss of smell, things like that, things that we've all heard about. If you're coming in later in your disease process, after that 7 days or so, that 10 to 12, 14 days, you're probably going to have more cough, shortness of breath, just an inability to get good oxygen, fatigue, things of that nature. But I have a patient up on the floor right now with a bone marrow transplant. Really isn't coughing or shortness or short of breath at all, but yet can't get the oxygen that he needs, and so he is on high flow oxygen for that. So it really varies. But those initial symptoms, I think, are what we've all heard about. The fever, fatigue, muscle aches, maybe cough and shortness of breath early on, loss of taste, loss of smell. Later on, it's certainly going to be more of the cough, the shortness of breath, the difficulty to get air, and just not feeling good. But we know that other symptoms such as this foggy brain or encephalopathy can occur as well.
All right, next question. With the increasing rate of COVID-19 patients in the hospital, how do you determine who is admitted and who goes home? And to add to that, we're getting questions today on, are people waiting too late to come? And is that why they're ending up on the vent and not doing well?
Yeah, so a lot of points probably to make in answering those questions. So first, the determination of who gets admitted to the hospital likely hasn't changed.
Nope.
Maybe since April. I think early in March, as we were seeing the first patients, there might have been some people admitted who we wouldn't admit now. But for the most part, admission to the hospital is
criteria.
Yep, the same criteria. And at most places, right, you're not getting admitted because you're positive for COVID-19. You're getting admitted because you need treatment for symptoms associated with it. And so that challenge, right, of a growing number of people who meet those criteria, but the same number of beds is part of our part of the tension we're feeling around capacity. As far as who goes home, we know across the country that there has been a push to send people home when they still have some symptoms, because we need to do so to make room for those who have worse symptoms. And so an example of what I mean by that is there are plenty of places that are sending people home on oxygen who were not on oxygen before they came in. Normally we think of oxygen, as being something that maybe patients with chronic lung disease, COPD, or pulmonary hypertension need in their home, not someone who had a pneumonia, like COVID, a viral pneumonia. But now it does appear that may be something that becomes more frequent as we need the beds. So a little bit of maybe nuance or difference there from where we might have been before. I don't know that we're seeing a whole lot of that here, but we know we've heard about it.
Yeah, absolutely. There are admission criteria, and what do those admission criteria entail or start with? It starts with the vital signs. That's why they're vital. So vital signs includes heart rate. Are you tachycardic? Is your heart rate above normal? Your respiratory rate. How many times are you breathing? What is your blood pressure? what is the amount of oxygen getting into your blood? Those are major criteria for looking at somebody if they need hospitalization or not. And just as Dr. Wild had said, that hasn't changed. If you need admission to the hospital, you need admission to the hospital. And just giving oxygen is probably not the best thing. So we certainly try to send people home if they are otherwise stable and don't meet admission criteria. But if you meet admission criteria, you are not going to get sent home.
What do you think of the study? Oh, no, sorry. If you have symptoms that tested negative, should you be retested? If yes, how long should you wait?
Good question.
Yeah, I'll offer up a first answer of, well, I think it depends. If the symptoms are the same and not worsening, maybe there's less value in retesting. If you have new symptoms, definitely be retested, even if it's the next day.
Yeah.
And that's the hard part. I would say the best answer here is contact your healthcare provider and be very specific with your answers to questions about what symptoms are we talking about. Are they same or worse? Is anyone in your household having those symptoms? Have you had contact with someone that's known positive? All those things will go into forming an answer.
And I think it depends what test too. If it's an antigen test or anterior nares as opposed to a PCR test and a nasopharyngeal swab, if that's negative, you definitely should follow that up with a confirmatory PCR test as well. But I think the best advice was given by Dr. Wild. Contact your healthcare provider. Or if you don't have a regular doctor, try to contact the local health department to look for some guidance on that as well.
I want to squeeze in a question by Lauren, and then we'll do the final three. Laura is saying that my niece who works outside the home and lives with my 80-year-old mom is setting up a schedule for Thanksgiving with family members so that they can come and visit mom one at a time and eat. What do you think about that? Is that safe?
Amanda?
Hi.
People are getting creative. You got to get.
They are being creative, but I think we have to really focus on if these are folks who are not normally in interaction with your family, it still is posing a risk. And so whether you have one person at a time or whether you have 10 people all in the same room, it's really a matter of, are you planning to wear a mask, maintain that social distance, and really reduce the likelihood of any kind of infectious transmission. So I think that could be a creative solution, but it doesn't mean that now you are kind of free to interact like you normally would. You still really have to be very cognizant of if you have any symptoms or if you don't feel well, don't go around other people. If you always wear a mask to the degree that you can and maintain that social distancing, good hand hygiene. So those infectious pillars or infection prevention pillars are still really important. And, I think in my opinion, is it safe? I think the safest would be to maybe do a Skype or a phone call, which is not at all what people want to hear right now. But I think there's too much risk of exposing that many different bubbles to one another.
Yeah, I would say, the person that, while that plan would do a good job of managing risk between the multiple families coming, mom still just had interaction with 10 people. Her bubble is expanded, right, greatly by that, unless, of course, there are people who are already in her life on a daily basis. But I would think that, the person probably at the highest risk, just based on age, would be mom, depending on how old mom is. And that probably should suggest that keeping mom's bubble small is probably equally or more important than any of the other people.
Yeah, I would absolutely agree. I think, we'd start as what is the definition of a contact, 10 or 15 minutes within 6 feet or more. I think there are understanding that there are things you can do to reduce the risk. The risk is never reduced to zero. So meeting outside, if you can be 8 to 10 feet apart, masking is important as well for that. Those things are very important. Keeping the time, if it's just to come say hi and be with somebody, keeping that time to 10 minutes or less. Those are things that you can do to help reduce the risk. The risk will never be zero, but we want to keep everybody healthy, but trying to mitigate that risk of catching the disease is the important thing.
This next question is something we got asked by a lot of people. What do you think of the study that shows immunity after COVID-19 might last a long time, even years? Will that be the same for people who get the vaccine? So what do you think of the study and
I think it's a very good study. It was done here in the United States, I believe. I think out in the West, California, UCLA, or something of that nature. Or maybe it was Cedars-Sinai in New York. Nevertheless, it's a good study. But what we have seen throughout this is different studies. Mostly, all of the studies have been with antibodies. So they show antibody levels that are rising, declining, staying stable. We've looked at studies from SARS-CoV-1 infection as well that showed antibodies. This study, I think that you're referring to, really talks about the actual cells that produce the antibodies, the B cells, but also the other component of the immune system, the T cells, which help to clear and destroy virus-infected cells in our body. I think it's a good study. We have just seen a lot of heterogeneous results from all of these studies. One study does not guidelines make or change in practice. So I think it's very interesting. It is, we're very optimistic from this, but we still need more real-life clinical experience as well as more studies and more data. We hope that it will be the same for the people who get the vaccine. However, we do anticipate that people will probably need a yearly booster of this vaccine or whichever vaccine is out there. I don't think we know that yet because the vaccine hasn't even been released. But I think most people, most experts do anticipate at least a yearly booster for the vaccine as well.
What is the percentage of staff at the health system who are either COVID-19 positive or out waiting for test results?
Great questions. There's been lots of stories lately about the number of healthcare workers that are out. A good story around Mayo Clinic, I think, catching a lot of attention lately. And so I did pull yesterday's numbers. We'll have this morning's. We update every morning just a little bit after 9. But yesterday there were a total of 466 employees that were either out on isolation. 206 of them were out on isolation, meaning they were positive. And that's a 10-day isolation period. So that's not a new number yesterday. That's the total number out. And another 201, I think, were out for, 260, I'm sorry, were out for tests being run or waiting on results. So they were either symptomatic and being tested yesterday or were waiting their results. So that's a total of 466, as I said. If we consider that our workforce in just Kansas City alone is about 13,500 people, that's right around 3.5%, which is far less than that in the general population, which is good. I think, we know that healthcare workers do have extra experience, training, understanding, all of those things in the pillars of infection prevention and control, and that those behaviors do tend to spill over into their personal lives. So we would expect to see that number being a little less than the general population, but it still remains hard. 3.5% of our workforce is not a small impact. Now, they're not all nurses or doctors or bedside staff. There are a lot of support staff too, which are equally important, right? The people who help make sure that our patients have food or can clean our rooms and keep us safe. So very real impact. It's not a huge percentage, but we definitely feel it. Amanda, I know your team works closely with those numbers and patients as well. Anything to add?
Yeah, I think it's important to add the piece of how they are getting it. And almost always they can identify a situation in which they are pretty certain it was a community-related activity. Maybe they went to a restaurant or they ate in close proximity to someone else without a mask on. And it really isn't related to the patient care that they're providing.
Yeah, absolutely. Great point. We continue to reinforce that. In our employees, in our workforce, we still find that the most common scenario for spread or transmission in the healthcare environment is actually in the break room. And that was repeated in the evidence from the Mayo Clinic study. This is really not something, a picture at all where we have healthcare workers contracting the virus because they're taking care of positive patients.
Final question for today. What are your thoughts on taking vitamins to protect against COVID-19? And D and C were the leading.
Yeah, I'm not a big proponent. So I would say that for the most part, in America, a lot of our diets do have these things. I think for just pure health, we don't really need to supplement too much. There may be things you want to supplement. I think taking vitamin D is very important for your overall general health as compared to some of the other vitamins, especially like vitamin C and things of that nature. But for protection against infection from COVID-19 or progression of disease, there is no evidence to say that those do help protecting you from infection or protecting you from disease. We know that there are studies ongoing, but there is really no data to suggest one way or the other that it will help or be beneficial.
All right. Well, Monday we will be joined by Mayor David Albee, the mayor of Kansas City, Kansas, and chief executive of the Unified Government of Wyandotte County. He'll be here to talk with us a bit about what we're seeing in virus transmission and spread across the Wyandotte and Kansas City, Kansas communities, as well as talk a bit about masking efforts and what our public health and elected officials can do to help on that front. Dana, final thoughts today?
It is getting bad out there. We see a lot of stories more and more every day now about surges, increasing infection rates. There's a lot of things that people want to do to protect against infection, taking supplements, taking vitamins. The most important things that you can do is really those non-pharmaceutical interventions that we talked about. Wear your mask, do your hand hygiene, socially distance, and really most important, because we have seen this happen now for the past several weeks, avoid large gatherings. That is going to be vitally important moving forward through these holidays, through this winter season.
Thanks. Amanda?
Yeah, I think to echo Dana's comments, I think my advice for the upcoming week is to really be thoughtful on what your Thanksgiving plans are, and if it's really worth it to engage with folks outside of your bubble. And that's not great news, and I feel like a Debbie Downer, but I do think it's something that we should all be really thinking about as we approach Thanksgiving.
And I guess I would end maybe with a little story. A friend asked me last night to join via Microsoft Teams her family to talk with her teenage grandchildren about sort of things in general related to COVID, but some specific questions that they had about what they could do to make sure that they were safe and to protect their family. Great conversation. And I was struck by their response when I said, we all have a lot of power right now, every one of us. We have a lot of power to make important decisions, the right decisions, as hard as they may be, about what we choose to do. And that power means that we have pretty significant control over how we keep ourselves safe, our friends safe, those we care about, right, our family, those we love safe. And that's for each of us to remember, I think, as we make decisions about what we do going into the weekend, into next week, into the holidays. And seeing these young adults really watch that sink in. Hey, wait a minute, I have something I can do. I am not sort of at the mercy of all this. I'm not being told what to do, but instead I get to choose. I have the power, I think was pretty impressive. And so those two young adults know who they are if they're out watching this morning. Thank you for that. And I'd offer that same story to each and every of you. Each of you, we have the power. Each of us has the opportunity. In Dr. Steit's words, we the people have the opportunity to make a difference. So be safe this weekend. Next week, we'll have Anil Gallmacher, one of our long haulers who was with us earlier this week, back on the update, telling us a bit about the health problems he had that began in April. He told us, as bad as it's been for him, it's been harder on his wife and family. Here are his words as we say goodbye for the week. Dr. Steitz will be back with you on Monday. Stay safe out there.
I firmly believed that as healthy as I was, I wouldn't get it. It wouldn't affect me. I even told my wife it wouldn't be that serious if I got it. The last time on the way to the ICU, my wife was watching mile markers and where we were at from Wichita to Kansas City because she didn't think I'd make it all the way this time. She was waiting to see where she'd have to call for help. an inordinate amount of labor and man hours and doctors and nurses to keep me alive and get me back, even up till now. You know, it scares me if enough people show up that need as much care as I needed to stay alive, if there will be enough services to keep them there or for people to recover. COVID didn't care what I believed, you know, it was there and it was waiting, you know, and I gave lip service to being careful, and I could have been more careful, and I wish I would have been.